Yeah. Yeah, I mean, I think, full disclosure, I feel I learned a lot from you on working with trauma and OCD together. So, as far as I understand from what I've learned from your good self, we can very much put trauma memories on an exposure hierarchy and have it as something to work with right away from the beginning. I think for me, the thing that I find so helpful with my clients is to really get those basic ACT skills in place to begin with. This sort of diffusion, acceptance, grounding, some connection to values and valued activities, to have all that in place first before ERP or trauma exposure, so that that someone gets the skills, they get the reason you're doing exposure work is to practice these skills and to learn psychological flexibility in the face of obsessions or traumatic memories or traumatic feelings, because it's not obviously, it's not always just memories. So yeah, for me, I think, very much put it on the hierarchy, work on it, and work on it collaboratively with the client, if they feel that there's a impact of that trauma in the present, but in some ways, of course, there will be an impact of that trauma in the present. It will be showing up in the anxiety and things they're experiencing. So yeah, that, and then have those core skills really well practiced, and then can definitely do ERP and trauma work together, I would say. And of course, hyperarousal and dissociation, hyperarousal, it's all very interrelated, isn't it? And I think that's such an important point. I guess I would probably assess that in different ways, obviously in the formal assessment and talking about what people are experiencing, and as you curiously investigate their experience of thoughts, feelings, urges, behaviors, everything that's going on in their life. Sometimes that stuff will just come out as you talk in. So there'd be one level with asking the right kind of structured questions within your assessment to see whether those sort of symptoms are showing up. And if someone's even aware of them, because often people aren't aware of that, are they? With dissociation, you just don't even know you're doing it. I mean, I experienced a lot of depersonalization as a kid, and I had a lot of dissociative stuff around the edges of that I wouldn't have even known was dissociating, like kind of just staring into space and numbing out and things. And I just thought it was kind of normal sort of behavior. So yeah, there would be that level. Then I would also be watching the person in session and trying to, explore their body language, their color, their tone. Are they giving signals of being hyper-aroused, the tone of how they talk, the way that if you go towards painful stuff, how they react and what they do, and do they show signs of dissociation at different cognitive levels, kind of more in the body levels. So definitely exploring that in session with someone. And then I think as you do the mindfulness techniques in ACT and also in compassion focused therapy that I do, you're doing it interactively. So you're talking with the person what's happening as you're doing it. And I think that gives you almost the best read, right, of those sort of symptoms. You very quickly get if someone's getting hyperarousal, because it would be very hard to practice mindfulness. To close your eyes even will be difficult. And so doing that interactive sort of practice and really checking in and what's happening, what are you experiencing as we're doing this, how's it going, and not always just taking the surface answer, because sometimes people just want to please the therapist and just sort of say, yep, no, it's fine, but you can kind of see in the face there's something more going on. So sort of digging in. Yeah, I think it would be those stuff and the behaviors of dissociation in life. Are they doing dissociative behaviors? And it can be very overt behaviors or internal behaviors. So yeah, I think it would be really digging into all of that for me. I mean, I love this practice. We've talked about it before, dropping anchor, this idea of these 3 steps. So acknowledging your thoughts and feelings, coming back to your body, engaging with the world around you. So the ACE. And I like to tweak it, a little bit with people who are experiencing a lot of hyperarousal or hypoarousal as well. With hyperarousal, actually maybe not doing too much internal awareness to begin with. It's almost like you just glance at what's happening. You just notice the different pieces of the thoughts and the feelings, the internal experience, because it might be too much to look at it too detailed at first. So you acknowledge it, you glance it, maybe name it, and then spend more time with getting into your body and very physically, to begin with a lot of people actually really, pushing your feet into the ground, stretching, breathing. If breath isn't too attached with hyperarousal, but it can be, maybe the breath, but certainly movement, and then engaging with the world around you and what you're doing. And very much it could be your senses and doing the 5, 4, 3, 2, 1 stuff with your senses, or it can be more of an activity. Actually, for a lot of people in trauma and hyperarousal, actually to get active, doing an activity might be a better way of beginning to ground and realize that you can get out of that hyperarousal panic place, and when you trust that you can move out of that place and be more in control of your attention and your actions, in the face of those feelings, then we might extend out the acknowledge phase and do a little bit more on that A part of it. So I do a lot of that. It's just acknowledging, getting into the body a lot, engaging with the world around. Interpersonally, doing it with a therapist if you have a lot of trauma, I think can be pretty essential. Really, if you're really being flooded with that trauma, there's something about being there with someone, describing, naming, someone helping you to place that memory in the past and realize it's there, to bring compassion to it and have a compassionate presence. So yeah, that's a long answer. The simple one is probably the drop-in anchor practice, and I've got that on YouTube, and Russ Harris in ACT has done a lot developing that, but you see it in lots of places. Almost any trauma therapist is going to have a version of that. It might not be so ACT focused, but they'll have a kind of version of that. Yeah, I think so. I think the trauma therapist Babette Rothschild says that that all the emergency services use exercise to regulate trauma. So why wouldn't a therapist actually? And why as a therapist actually we should be doing that to help us with everything we're getting vicariously, perhaps in that situation. I think also there's a sort of nuance to it as well, because as we've talked about many times, it's the function of the exercise, isn't it? Because I've worked with people that have had trauma histories, and then the way they exercise is pretty traumatic in itself. There's almost a persecutory thing. So I think we have to find the right balance of what is the time to get aerobic and push your system and get it into higher heart rate. What is the time to do more strength-based training and get that kind of sense of strength and stability in your body? And then what is the time to do something more chilled and yoga-esque or kind of calm and really, sometimes we can do that on our own and kind of find that blend of exercise that works best. But sometimes we need that external feedback, because especially with high achieving clients, I've had a lot of people that when you hear how they exercise, it's just another stressor on the system, really. And it's sort of pushing that hyperarousal even further. So but yeah, I think exercise is just incredible, and that's how traditionally humans discharge trauma like any other animal, right? We're a species that we would have, a lot of people believed we tracked and hunted down our prey for hours and hours and hours, of aerobic exercise. So we're kind of built to do that. And if we're not having that going on in our system, then I think it can be it doesn't help us process that stuff. Yeah, I think I think there's a lot in the research and a lot in the OCD world of making that distinction, that there isn't that overlap with trauma as much as people might worry about. But I think often there is. I often see that with certain sort of distressing sexual themes. There is often a sexual abuse history, or there has been in a lot of the clients I've worked with. And I think, really it's the same skills anyway with that. That's the brilliant thing. So, if an intrusive thought is just a random obsession which has no relationship to our history, okay, we can use our skills with that. But if it's a obsession that does have a hook back into the past, we can use the same diffusion skills to watch that thought, to let go of the compulsions, and to engage in things that matter. I like to do compassion work on trauma history. So, I would note that down, and certainly, if someone wanted to collaboratively go back and work compassion on that trauma history, I would do that. But I have had clients with trauma histories who don't want to do anything about the past, and actually we've just worked present moment skills and act skills now, and they've had great recoveries. So it's not like, I don't think you always have to do the work on the past. I've also had clients that are kind of scared to work on the past because they feel that it exacerbates their OCD symptoms. I think that often happens. And so sometimes that can be true of people with trauma. So I would want to get the skills really strong with OCD first, so that we know we could go back into the trauma and it's not going to hook us into a load of compulsions and pull us back into OCD loops. So, sometimes I've done that with people who work more OCD skills in the present, get really strong at that stuff, and then go into the trauma and the history and extend compassion to all of that. And then I've had some people that, the OCD symptoms have only improved when we've done, the work on the past, the trauma. So, there's it's difficult, isn't it? Because it's quite client specific, and it's quite, kind of working with them and seeing what's the bit that's impinging on their present moment experience, really. What do you think? Yeah, I think, I've certainly worked with a lot of people that, their system was already, in that burning out zone, really. The hyperarousal was so high for so long, and then they were pushed in pretty intense ERP pretty quickly. And they certainly describe an experience of sort of burning out and sort of being numbed out, and maybe the OCD improved actually in certain ways, but they were kind of burnt out, numbed out, a lot of depression around the edges, other things was happening. So, I would say the way I feel like you get around that is getting those core skills in place first before doing the work, and the lifestyle balance, so that we know people are doing valued actions that are, well-being promoting, exercise like you talked about, social connection, engaged in meaningful hobbies, things like that. All of that, seemingly very simple stuff in place first, and those diffusion skills of being able to really watch obsessions, put down compulsions, and control the attention in the presence of all of that, be able to accept difficult feelings, so we're not fighting with them and intensifying them into more traumatic feelings, so that we're able to allow the feelings to come and go without them pushing into that high hyper and hypoarousal. If we do go into hyperarousal, we know how to come back and get the body woken up and back. I would want to get all of that really in place first. And I've done that with people who've described being sort of traumatized by exposure work. And then we go at it again gradually, and they're doing it very different. It looks very different. We're not just white knuckling the exposure. We're actually doing it to practice skills that you can then take into life and actually improve everything. So that would be my thoughts on it. Get those skills in place much stronger. Yeah, completely. So I think, looking for what's going on mentally, are you reducing the physical compulsions, but actually there's tons of mental compulsions. I think when you talk to someone and how they describe exposure work can often tell you that, if there's a lot of aversion and they're not really connected to why they're doing it, and it's not translating into behavior change in life that is adding to a richer, fuller life. It's just like, I was doing tons of exposure and it was really awful and tough and difficult, and I didn't, and they describe it like that, then you know that it's just pushing, and there's no, useful skills that are coming into life that mean they can start doing things they couldn't do before, or meeting people again, or doing activities, or so I would look for the behavior, the interaction between behavior and life, between how we're meeting the emotions. Are they describing it as incredibly aversive, horrible experience, or are they describing it in a diffused, accepting, compassionate way, with those skills in place, connected to a meaning and purpose? They know why they're doing it, and it sounds so different. And I think that the second one, when all those processes are in place, it's not going to burn people out, because it's invigorating you. It feels great. You're getting your life back. The other one, people do then get knackered in their life. They're so tired, they're burnt out. You might see numbing, depressive symptoms coming up more, or like you say, the compulsions are peaking, and or different compulsions are coming in, and they're increasing a lot. And actually there's no behavior change, and no sense of skill change. That's the stuff I always look out for, and I hear a lot in people, actually, because often ERP work is not framed that way.
No, that's
Yeah, I think that I would see this partly from my compassion focused lens, that there is often a lot of grieving to be done with mental health recovery. So it can be about creating a space where you can do that safely, and do a self-compassion practice like the kind hand, and be really kind and supportive, and allow that. And you could even, within ACT work, you can also go, is there any memory in this feeling? You can actually go, does this have a root in the past? And, Stephen Hayes talks about that a lot in some of his newer book and things, like discovering, is there any information in that kind of blend of emotion, and that sadness and that grief. But if it's a grief that feels like it's more, there's fusion and avoidance, and it's disrupting life, then I would want to tackle that more with acceptance, diffusion, valued action. Can we get better at being with that feeling and doing what we care about? So it can be, sometimes to work with a therapist, is there a grief process that needs to be done there as part of deepening self-compassion, or is it a emotion that we're actually stuck and struggling and experientially avoiding, and actually we just need to work more diffusion, acceptance, present moment skills, and compassion to help with it. That would be a quick thoughts on it. It's quite a big topic though, and I relate to that. I've felt like that in the past. I've had that kind of unknown sadness, like deep kind of grief sort of feeling that's been there in the background at times. It can be a tough one.